Let's pick up where we stopped. We are talking about risk factors of premature rupture of membranes. We said smokers, people who smoke cigarettes during pregnancy, sexually transmitted infection, as we said, they can weaken the amniotic membrane, previous history of preterm labor, people who has had vaginal bleeding or have uterine distension like polyhydromnious, or even multiple pregnancies. All this can cause premature ruptures of membranes. Procedures that may result in preterm rupture of membrane, which may include cervical silage and amniocentesis. Cervical silage, that is, those procedures which they may use, like Schrödinger stitching, then chorioidicidal infection or inflammation, etc. Signs and symptoms of premature rupture of membranes. The mother will report painless leakage of fluid out of the vagina. They may notice it as either a gush, and these mothers will report with wet clothes, or a steady flow of small amounts of watery fluids in absence of labor. So these mothers may also come in with pads and reporting changing pads frequently. So it is maybe one of the signs of premature rupture of membranes. So this mother can also report that loss of fluid may be associated with the fetus become easier to feel through the belly due to the loss of the surrounding fluids. It can be associated with a decreased uterine size or meconium. So, diagnosis. How can we diagnose? History taking, physical examination, and laboratory, as usual. So the ultrasound, we shall measure the amount of fluid which is still surrounding the fetus. And if we detect that there is premature rupture of membranes, we can assess, is it now oligohydromnious or is it still in normal measurements? So for the general management, the mother with preterm rupture of membrane should be kept in a maternity. Why? Because any time labor is going to start. So we do the general examination plus the abdominal examination. We can also assess the degree of cervical dilatation. So on history taking, the mother will report a sudden gush of fluid with continuing leakage. So you go ahead to ask whether the mother is contracting or the gush of water is associated with any bleeding. And we can also ask a history of sexual intercourse or even fever. It is important to verify the patient's estimated due date because this information will tell us the management. So we shall be able to go ahead to ask the patient when is their expected date of delivery, or even we can calculate it because this can give us the way forward on how to manage this patient. So on examination, perform general physical examination, abdominal examination, ruling out the fundal height versus the gestation age. Speculum examination to evaluate cervical dilatation and effacement should be done. When preterm pre-rupture of membrane is suspected, it is important to avoid performing a digital examination as it will irritate the cervix and aid cervical dilatation. Evidence of fluid pooling in the vagina or leaking from the cervical os when the patient coughs or when the fluid pressure is applied will help determine PROM. So we shall ask the mother that when you cough, do you feel the fluid flowing? Or when you put on the arm on the fundal side, Is she feeling a gush coming in? All this will help us determine the method, the management next. So here another key investigation is to use a litmus paper and examine what is exactly coming out. The normal pH of the vagina is between 4 to 6, whereas the pH of the amniotic fluid is acidic, that is 7 to 7.3. So we shall, when we use a blue litmus paper, that is, it will turn to red. That is meaning it is, and if it remains blue, then it means it is still the normal pH of the vagina. But if it becomes acidic, then it means it is amniotic fluid. So instantly we give medications like corticosteroids intramuscular, 6 milligrams every 6 hours for at least 2 days to allow fetal lung maturity if there is anticipated premature delivery. Here, if we think that the mother is going into labor and the fetus is still below 37 weeks, we think that the lungs are not yet mature. So we give dexamethasone, which may aid the growth of the surfactant in order to aid this baby live extra uterine. Then we also give antibiotics that preferably ampicillin or erythromycin or amoxicillin in order to prevent infection. So we give it as a prophylaxis. We can also administer tocolytics in order to prolong the latent period. Why do we administer tocolytics? These ones are going to aid us move from the maternity center or to the hospital. Or they are also going to aid us prolong the onset of active labor as we plan for what is next. So with these few remarks, amniotic fluid disorders are also well covered. Good day.